So I have been asked to give some comments on how the guidelines would judge this case and similar cases. So these are my disclosures. Now, of course, we all know what we are speaking about, the Francois-led guidelines, and you will see this slide hundreds of times, yet it is very popular. So we still need to understand what kind of patients we are dealing. Of course, we are dealing at the bottom of this pyramid here in the very high-risk population. Now, if we see the European guidelines have indeed enlarged, quite importantly, this very high-risk population. But patients like this one are within this high risk. What I believe is a clinical cardiologist that have always worked in the chronic care unit, the most important component among the high risk. So somehow you could even say they are the high risk in bold, or the high risk indeed. And these patients with recent acute coronary syndrome, such as a recent myocardial infarction. And indeed, this is true if you compare this a little bit with the American guidelines. This argument has been brought to you already. These are stricter guidelines in their definition of high risk. And yet, if we would even use this stricter guidelines, we would definitely include this patient among the high risk, because this patient has indeed a recent acute coronary syndrome, and indeed it has additional high-risk conditions, such as very high LDL and even additional risks, as you see here, which are mentioned with persistently elevated LDL cholesterol. So there is no question this patient is a high-risk patient, no matter which guideline you are looking at. And of course, if you are looking to the European guideline, we all know now that there is the double target of more than 50% reduction, as well as the 1.4 millimole or 55 milligrams as in per deciliter as a guideline. And of course, we also know that if the patient has additional events, such as an event within 2 years, we even need to be lower, below 1 millimole or below 40 milligrams per deciliter. And of course, this is a stricter goal as compared to the previous one. You will all remember until just a few weeks ago, we were off with a 70 milligram per deciliter goal, or 50% for patients who were just below the 140 target, in order to have them even lower compared to the 70 milligrams per deciliter. Indeed, I have made a little bit of an example of what is the difference that we are now facing with the new guidelines. Now, if we start with a high value, it doesn't really change the goals, because we are now moving from 70 to 50. So it's very easy. We use the goal as our target. And actually, the same is true if we go to 140. Then if we go to 100, we would have used the 50% goal before, and we use the same right now. So it's one of the few occasions in which, no matter which guideline we use, we would follow to the same target. Whereas if we are at 50, we would have been good enough with the previous guidelines, and now, although this is a very unusual circumstance, we would now be required to halve this treatment if we started with a naive value of 50, which is quite unusual, to tell you the truth. Now, of course, we know what we can expect from our values. And of course, if we don't have a naive value, we can use this calculations I made for you, and you can easily made, which is the backward calculation. In other words, if you have a patient who comes on a high-intensity statin with 50 of LDL, you can imagine that his baseline is roughly the double. If you come a patient with a moderate intensity statin, you can imagine that roughly you will need to add 40% to reach his naive value. So this would be a little bit an aid in order to understand what is the naive value, which is the one which is needed in order to set the proper goal for your targets. And so how do we reach that? Now, this has been shown already, and it's obvious that we need to start with high-intensity statin, and we should use a combination with ezetimibe, and we can discuss that this patient by Françoise went directly to PCSK9 inhibitors, in this case also to the advantage of a clinical trial, but in general, some patients and some physicians may eventually decide to jump directly, but our guidelines do indicate that we should have a stepwise approach. And of course, if this is not reached, then we have a class 1 indication for a combination with PCSK9. So this is the treatment flow, and we can see what happens to this patient. So the LDL goal was not reached, so we would have needed to add ezetimibe first, and then at the subsequent level to add PCSK9. And this is indeed what we tend to do in our daily clinical practice. So I think I can stop here and hand to the subsequent speaker. Thank you.